Hi, I'm Romaine Bennett.
I'm Mina Hanna, and today we are discussing two cases, attention deficit disorder and intermittent explosive disorder.
Meet Jack. He's a 7-year-old boy in the first grade who enjoys spending time with his friends, swimming, running, and skating. He lives in Toronto with his parents. At school, his teacher notices he's hyper focused on activities that interest him and has difficulty concentrating on those that don't. He does attention seeking behaviors such as blurting out answers and interrupting other students. He has difficulties following, listening to instructions, sitting still. He is restless and constantly needs reminders to keep him on task. Jack's parents note challenges following staying asleep. He also has problems following routines at home, remembering instructions. He can be defiant and has incidences of hitting, crying outbursts, and other inappropriate behavior. His parents note that this has been going on since age 4 when he was in preschool. And Jack also notices. He says, despite his best intentions, he just can't stop. Pertinent positives in the psychiatric review of systems include defiance, attention seeking behaviors, difficulty concentrating, hyperactivity, sleep disturbances. And he's also slightly delayed for his age, as he can only recognize a few sight words, such as you, up, and down. Upon exam, Jack's behavior is quite distractible. It was really hard for him to keep focus. He was constantly spinning in his chair, picking up various objects in the room. He's very active, hyperactive, and very fidgety. His thought process was every answer was filled with excessive details, and he would veer off topic. He had no hallucinations or delusions. Jack is oriented, short attention span, but able to interview, and his insight and judgment was not impaired. For assessment, first thought about autism disorder. Ended up not including it because he did not have social disengagement, isolation, tantrums, isolation or tantrums. Anxiety, I thought about that as well too, but ultimately did not include that because his criteria did not have any worry or ruminating thoughts. ADHD, definitely chose that one because he did have these symptoms in two different settings at home and at school. He was had inattention. He had problems focusing. He was defiant. He was forgetful. He had hyperactivity and impulsivity. He was restless, couldn't keep still, excessive talking, blurting out answers, interrupting. His symptoms started prior to age 12 and going on for at least 6 months, and they were noticed when he was first age 4. For treatment, there is psychoeducation, which this is educating Jack and his parents on what ADHD is and treatment options. This will also encourage shared decision making. School accommodations such as 504 or an IEP. A 504 plan can provide Jack more time, modified assignments, organizational tools. An IEP, which is individualized education program, can provide specialized instructions, behavioral management strategies, and tutoring. Jack can also receive preferential seating to help him keep focus. Third, psychotherapy such as CBT, parent support, and talk therapy, and also medications. So for medications, stimulants are most commonly used in the treatment of ADHD. They come in short-acting and long-acting forms. Most common ones are methylphenidate and amphetamines such as Adderall or Vyvanse. Non-stimulants can also be used for various health reasons, such as increased anxiety or other growth concerns. Other options include clonidine and guaifenesin, which can be taken 2 to 3 times a day. Bupropion is also can be used, but it's also more appropriate for adolescents and adults. And then TCAs and also modafinil can also be used, but they're rarely used due to lots of side effects. Other considerations include stimulants, monitoring their side effects. Stimulants are known to cause loss of appetite. So a thought would definitely be to advise Jack's parents give him a snack with when taking the medication, and also, had taken medication with a meal, and also providing an evening snack. They also can cause insomnia, so it's important to educate on good sleeping habits, no caffeine, and avoid an even dose if needed. Dizziness and headaches can also happen, so monitoring vital signs, encouraging hydration, and a midday snack. Fatigue is commonly seen upon administration initially, but it doesn't improve. If experienced continually, those can be divided. So also to follow up with Jack's pediatrician and to monitor his height and weight. Now I'll turn over to Mina.
All right. So Celeste is a 11 years old sixth grader living in West Palm Beach, Florida, with her parents and older brother. She was previously an A and B student, but over the past 6 months, her academic performance has declined markedly alongside escalating mood and behavioral issues. Her parents describe daily irritability and outbursts occurring around 5 times per week, lasting for 10 to 30 minutes. Those episodes are often triggered by perceived rejection, transitions from preferred activities when being told no, or family stress. During episodes, Celeste screams, uses profane language, throws objects, and becomes physically aggressive, hitting, kicking, and sometimes biting. Afterward, she typically shows no recollection of the event, followed by tearfulness and remorse. Socially, she connects more easily with adults than peers, which has made maintaining friendships difficult. Her family reports that these outbursts have disrupted vacations and led to withdrawal from outside activities. She is now homeschooled, which has further limited her social engagement. The chief complaint, as reported by Celeste's parents, frequent episodes of anger and explosive outbursts escalating over the past 6 months, leading to significant distress for the family and school avoidance. At baseline, she is rarely happy, displays persistent irritability, no longer participates in social or recreational activities, and family avoids travel to prevent meltdowns. Episodes typically arise when she feels rejected or controlled, and despite her remorse afterwards, she struggles to control her reactions. She has also expressed a feeling of worthlessness, saying things like, you would be better off without me, though she denies any suicidal intent or plan. There has been no evidence of mania, depression, psychosis, or substance use, which helps narrow the differential. Uh, those are our positive, uh, pertinent positives and pertinent negatives, as we've discussed, like daily irritability, outbursts, rejection, being told no. All pertinent negatives that we've mentioned, including mood elevation, decreased need for sleep, or grandiosity, all those are negative for any psychotic symptoms. On exam, Celeste was well groomed and cooperative. Her speech was normal in rate and rhythm. She describes herself as rarely happy, with an irritable and sad baseline mood, and her affect was congruent with that mood. Her thought process was logical and no hallucinations or delusions. She was alert, oriented, and demonstrated remorse and insight when reflecting on her behavior. Importantly, she denies any active suicidal thoughts. These findings are consistent with emotional dysregulation rather than psychosis or mood disorder. For assessment and differential diagnosis, the primary diagnosis here is intermittent explosive disorder, which is characterized by recurrent behavioral outbursts representing a failure to control aggressive impulses out of proportion to the stressor and not better explained by another mental disorder. Let's look at the differential here. So disruptive mood dysregulation disorder has been ruled out because her irritability is episodic and not chronic. For bipolar disorder, there is no sign of mania or hypomania. For oppositional defiant disorder, while she argues and resists authority, her behavior is episodic, not persistent. For ASD, though she has social difficulties, there has no restricted or repetitive interests. Uh, our last differential is PTSD. There has no trauma history reported. For our treatment plan, treatment approach for Celeste focuses on psychotherapy as a foundation, and medication is considered as an adjunct if needed. Psycho diagnostic plan first. A full psychiatric evaluation will need to be to screen out any depression and anxiety, ADHD comorbidities, or any prior trauma that may not have been reported. Also assess for suicidal risk because of statements of worthlessness that she has stated. Psychotherapy, mainly CBT, cognitive restructuring, relaxation, coping skills training. CBT will focus mainly on identification of triggers, challenging distorted thinking, and teaching alternative coping skills. Parent training and family therapy also will be helpful to de-escalate conflicts whenever she experiences an outburst. For pharmacotherapy, mainly first line of management, if medications will be used, will be an SSRI, and the SSRI of choice in that case is going to be fluoxetine. We start at a 10 milligram daily dose, and we're going to be increasing slowly. Usually no other med is being given unless an SSRI fail to reduce the outbursts. And in that case, we're going to be moving towards something like the Depakote or valproic acid. But in that case, we're going to need to be monitoring for the much more aggressive side effects of it. So it is important to engage the family in shared decision-making, reviewing benefits, risks, and monitoring requirements for either one if she ends up being on any. And thank you so much for listening.
Thank you.
And those are our references here. Thank you.